Remember, chest X-ray, ionizing radiation. Remember that the X-ray passes through matter and capture all the things that are passing through. In this case, a human torso. Okay, so that's why we can see structures that are anterior, but also structures that are from behind. Okay, so don't think it that is only like a single picture that we only see the front or we only see the back. We can see both because they pass through. But because depending on where the ray is entering, we're gonna see more clear the thing that is where the X-ray is passing first, and then later, and vice versa. Okay? So if we're talking about X-rays, remember that we're talking about densities. Okay? That's why it's possible to distinguish different body parts in our, in this case, in our chest. Okay? We are passing from black to white, and in between we have shades of gray. Okay? Then we have certain limitations because if both tissues, structure, whatever, is the same density, we cannot see the difference. The best example, the diaphragm and the liver, we cannot distinguish both because they are the same density, so we only see like one single white picture and that's it. We know that is the diaphragm there, okay? And we know that beneath that is the liver, that is of course part of the anatomy knowledge, but we cannot see it right on the picture. Okay, so it's starting from black. Remember, if it's black, what kind of density is? It's a lower density, and which is the lowest density of all? Air. Okay, so if it's black, it's air. Okay, could be regular air, could be gas. Okay, so this is something that you have to take into account. So in this case, the thing that you see dark, that is black, is because it's the lung. And why it's like that? Because remember that inside the lungs, the air is passing all the time, constantly, so that's why it appears black. Then, dark gray, okay? We can consider dark gray the breast silhouette because the composition is what? Of the breast. Fat tissue, okay? So fat tissue, it's denser than air, okay? But it's not as dense as metal, okay? So that's why it's a shade of gray, and it's something that we consider dark gray. Light gray, such as heart or any other blood vessel or blood, okay? We can see it on the X-ray. Off-white, such as the clavicle or any other bone, okay? And when it's plain white, okay, it's going to be something metal, but also if the liquid, in this case, if it's blood or if it's any sort of infectious liquid with a lot of fluid material, could be so viscous, so concentrated, that could be turning completely white. Okay? So take that also into account. So in the chest X-ray, remember that we have to check all of these situations, but in order to have a better assessment of the X-ray, we have a mnemonic, okay, in order to have a better approach, okay? So it's the A, B, C, D, and F, okay? Remember, A for airway, and we're gonna see the trachea. B for bone, and we're gonna be seeing clavicles and ribs. C for cardiac, and we're gonna see the cardiac silhouette. D for diaphragm, and we're gonna see right and left MI diaphragm. And E and F, we're gonna compare always the bone fields from the right and from the left. Okay, so let's begin. Remember, airway, the trachea. The trachea should be centered. How can I know that it's centered? Because also what is on the center is the vertebral column. And the vertebral column has these particular structures that are called spinous process. So the trachea and the spinous process should be parallel aligned. Okay? If you see that the spinous process are straight, but the trachea that is behind, and how can I know that it's the trachea? Because it's darker. Because it's a tube where the only thing that passes through is air. So that's why it appears darker. So it should be aligned at the spinous process. Could be deviated towards the right, towards the left, okay? And that is going to be pathological. In a physiological situation, in a regular person, should be always centered, okay? Then the bone. Remember, check only two types. The clavicles on the top and the ribs that we can see. The clavicles check that are entire, okay, that are not luxated, not broken, and most important is going to be the ribs, okay, because you're making a chest x-ray, okay. Not only check angulation and composition, okay, that are everything like uninterrupted, not only check fracture, but also check the intercostal spaces. Check that intercostal space should be the same from one side to the other, always, okay? And check also the angulation of the ribs. Should be a little bit angled, okay, as you see. But in terms of having a lot of air trap, they can start becoming a little bit more flat, okay? We're gonna see that on the pattern. For example, on atelectasis, when you have a pneumothorax, okay, check the size only and check the intercostal space. We're gonna see a picture about that that drastically changes from one side to the other. So that's why always, in terms of the lung, compares, okay? The cardiac, remember, if it's cardiac, we're gonna talk about silhouettes, okay? So, right and left silhouettes. Beginning on the right. Why beginning on the right? Because it's only one silhouette, okay? That is this one, that is belonging to which structure of the heart? The what? No, right here. The right one. Remember that we're seeing the patient like this, okay? The right atrium, okay? This is the right atrium. And it's the only silhouette that is going to be visible on the right side. That's it. What about the right ventricle? It's completely hidden by the vertebral column. Remember that the heart is making like a torsion and going left. So that's why it's hidden, okay? Let's go back a little bit. Right here. The right ventricle that is right here is completely hidden by the vertebral column. Okay, so that's why it's not visible. Then, on the left side, there are more silhouettes, going always from top to bottom, okay? Which is the first silhouette that we see on the top? This one right here. The aortic arch, the aortic knob, the aortic knuckle is the same. It's when the aorta goes up and bends down. That's the aortic knob, okay? That is the first silhouette on the left side going from top to bottom. Then, second one, what is going to be? The pulmonary trunk, okay? Is the trunk of the pulmonary artery, okay? That is going to be seen right here. Remember that the pulmonary artery emerged from which chamber? And so it's a trunk first, and then it's going to be a division towards the right and the left lung, right? Very well. Then the third bump or the third silhouette, okay? What is going to be? The left what? No, atrium. First is the left atrium. That is going to be right here, okay? And lastly, and the biggest silhouette of all, okay, on the left side, and it's going to be on the bottom, is going to be the left ventricle. Okay? So, don't get confused about that. In diaphragms, guys, okay? Diaphragm, remember that we have, yes, only one diaphragm, but in terms of chest x-ray, we're going to divide it in two portions, right and left. MI means half, MI diaphragm, okay? So we have on the right side, and we have on the left side. We have to take into account two main things, okay? The angulation, okay, that is made with the heart, but also with the ribs, okay? And also the elevation of the diaphragm, okay? In order to see, firstly, if it's a normal position of the x-ray, but also we can detect if something unusual is happening, such as, for example, an hepatomegaly is going to be different, okay? So, simply because it's the liver beneath, okay? The right hemodiaphragm is going to be slightly elevated towards, okay, the left one. Okay, so that is also, you can know that this is going to be the left side. Okay, it's simply because it's slightly elevated, okay, against the left one. Secondly, the angles. Okay, two pairs of angles. The first angle made by the heart and the diaphragm. What is the name for that angle? No. What? heart and diaphragm. Another name for heart, cardio diaphragmatic angle or cardiophrenic angle, okay, is going to be this one right here. It's the diaphragm and the heart create that angle on both sides, okay? Should be visible always if the person is considered healthy, okay? When it's vanished, okay, one of the most common conditions is consolidation that vanish that angle. Why? Because consolidation, as you know, the most common pathology that makes consolidation is pneumonia. And the most common clinical scenario on a chest x-ray on pneumonia is to be on the base of the lungs, okay, at the base of the lungs. The other angles between the costal border and the diaphragm, there you go, is the costophrenic angles, okay? These are the ones that are more sharp, okay? And you see two of them. The way is going to be easier way to be managed is when you have pleural effusion, accumulation of water inside the pleura. So that's why, because of gravity, when the patient is standing up, all the water goes down and start like feeling this particular edge. So that's why you don't see it anymore. Okay? That's right. Then on the equal long fields, remember, always compare the apex, the middle part, and the base. Always compare one and the other. But careful, guys. When you see this blurriness right here on the side and at the middle, okay, of the chest x-ray, that is completely physiological. Why? Because remember that these are the ileal structures. At this particular part of our body is where is the entrance and the exit of the bigger structure that entering and exiting from the lungs, okay? Such as the pulmonary arteries, the pulmonary veins, the bronchi, okay? So that's why if it's larger, it's thicker, it's denser, and it's more visible on a chest x-ray, okay? So that's why it's going to be seen at this particular side, okay? So don't get confused that it's a consolidation or it's something pathological. No, okay? You have to see it from one side, but also on the other side, but at the medium level, okay? Position, guys. Remember that if it's a printed x-ray, in order to know that it's well positioned, we have three parameters: two anatomical structure and one that is made by man, okay? So the first one is to check the cardiac silhouette that should be always towards the left, okay? This is the first one. Second one, the gastric bubble beneath also should be on the left side of the patient beneath the left diaphragm, okay? And the third one, you have to check an understandable name tag, okay? So those are the three structures in order to see that is well placed, okay? Remember, the inclusion in order to see that everything should be fit in, everything should be entering on a chest x-ray. Okay, so all the costal border should be visible, okay, in all this composition, okay? That is going to make a good quality of chest x-ray. In the checklist, of course, remember that it's important to know about projection, alignment or rotation, inspiration, penetration, and also the cardiothoracic radius. So, projection. If you want to see the patient on the frontal view, okay, we have two types of projections. Remember, one that is called posterior anterior, that because of the beginning of these two words is PA, and that means that the x-ray comes behind the patient, posterior, and exit anterior on the patient. So that's why it's posterior anterior. The anterior posterior is completely the opposite. The x-ray enters from the front and exits from behind, right? What are the main differences? Okay, these are for ambulatory patients that they can stand up and go to the x-ray lab. These ones are for non-ambulatory patients that they cannot walk, patients that are on the bed. Okay, so that's why we have to change the direction of the x-ray. The way we distinguish one and the other. Okay, same patient, same time, different projections. PA versus AP. PA ambulatory, AP non-ambulatory. Okay, so the first thing that you have to notice, okay, on a PHS, the angulation, okay, of the clavicles is making like a B shape, okay? You see it right here? Why? Because remember that one of the indications for the patient in order to have this X-ray is to hug, okay, the X-ray film. By doing this hug, the angulation of the clavicles is making this V shape, okay? This is one. And the other one, that the shadow of the scapula, okay, on both sides is not visible. Why? Simply, again, because you are like grabbing this, you are putting away your scapula, so that's why it's not visible on the X-ray. The opposite, an AP chest, only imagine guys, a patient seated or a patient on the bed. So the scapulas is going to be at the same level of the lungs if I'm doing like this, okay? So that's why the scapula silhouette is visible, okay, at the level of the lungs, okay? And simply because the patient is not doing this, okay, it's a little bit more flat, okay, the angulation of the clavicles. Because the patient, instead of being like this, it's like this. So the clavicles are even. And it's not making this V shape like in a PHS it does. Okay? So careful about this. Okay? These are the two main ways in order to know if it's an AP or if it's a PA. An AP projection, okay? Remember, okay, so if it's AP, it's non-ambulatory, so the scapulas are visible. Okay? But if it's a PA, the patient is walking, is hugging the X-ray film, so the scapula that are not in the inside. It's more on the outside simply because of the position of the patient. If you want to see a side view, we order a lateral projection, that is the other way, and this is the result, okay, that is going to be seen. Remember, this other projection, we can check vertebral column, we can check the sternum, but also in terms of the lungs and the heart, we can check profundity, okay, of any lesion that is causing. Okay, so if it's more anterior or more posterior or it's in the middle, the situation that we're seeing on a frontal view situation. Remember about this, RIP, rest in peace, in order to see rotation, inspiration, and penetration to check that the technique of the X-ray is okay. So let's see one by one. The R for rotation or alignment, okay? So remember that the spinous process that I mentioned before, this is something that you have to take into account in order to see rotation. The spinous process and the clavicles, the distance between one and the other should be even, and if they are even, the patient is not rotating, is well aligned. It's like this, okay? But if the patient is going to the left or going to the right, we're going to be having discrepancies and the picture is not going to look the same. If the patient is rotated to the left, the heart size is going to be exaggerated. Maybe you think that the patient is having cardiomegaly, but no. And the opposite, if it's towards the right, could be underestimated. Okay, it seems like a short size heart. Okay, so how can we know if it's towards the left or towards the right? Again, because of the distance between the spinous process and the proximal edge of the clavicle. If the distance is larger on one side, towards that side is the rotation. So right here, the distance that is more increased is on the left side of the patient. That's why the rotation is towards the left. Okay? So remember that it's pretty easy. Okay, it's proportional like to the side that is going to be affected. Another example right here, the distance is larger where? On the left side, right? So that's why it's in this case is larger the distance, so that's why it's a significant rotation to the left. The penetration, remember the amount of ionizing radiation, the amount of millisieverts that are the scientific unit used in order to make any sort of X-ray. So the amount of this penetration is going to be repercuting on the chest X-ray. If it's under exposition, low millisieverts, you're going to be seeing like this, okay? Now practically the vertebral column looks like a white line, and that's it. You don't see the division of the vertebra. You see only a white line, like this, and this is an under-exposition. An over-exposition is going to be completely the opposite. The vertebra is going to be seen quite visible all the way through. You're going to be seeing the division, okay, very, very well. But when it's a correct penetration, it's going to be slightly, the vision of the vertebra is going to be slightly visible, okay, against the cardiac silhouette, like you're going to be seeing right here. It's not a white line, but neither is plenty visible, okay? Remember the names, the colloquial names, but not colloquial is part of the medical terminology. If it's under-penetrated, how it's called? Soft. And if it's over-penetrated, hard, okay? So maybe on the clinical case, is not going to be saying over-penetration or under-penetration, is going to be named as soft and hard, okay? So careful about this. And the expansion, guys, remember that if you want to make sure that your chest x-ray has a full inspiration and you're taking a good shot, okay, on your chest x-ray, at least you have to see 6 pairs of ribs visible on your chest x-ray. Less than 6, the expansion of the lungs is not 100%, okay? How this is accomplished? By making or giving the command to the patient to have a deep inspiration, hold it, and then we take the shot, okay? Why is that very important? Because in a low inspiration, we can commit mistakes in terms of diagnostics. We can think that the patient is having something, like in this case, a presumptive consolidation, but when in fact the patient, the only thing that happens, that the patient does not insufflate the lungs as it should be. And in certain situations, mostly in emphysema, when a lot of air is trapped all the time, and if you, again, give the command to inspire a little bit more air, you can have something that is called hyperexpansion, okay? And how do you know that? Because you check the MI diaphragms, and it's going to look completely flat, okay? It is not that angle, okay? As before, you see the angles, okay, right here. In this case, it's completely flat, okay? So that is hyperexpansion. Yes?
That can happen if the patient does a forced inspiration?
No, if you're healthy, you cannot like overpass only with air the diaphragm strength, okay? Because the diaphragm has quite strength. But in a person that chronically has a lot of air trapped in their lungs, is capable to do so, okay? And the cardiothoracic radio, remember guys, to check if it's cardiomegaly or not. Very easy. First line in the middle of the vertebral column, from there towards the right, the more distant point on the right silhouette, at this point, you make a perpendicular line. The same thing on the opposite, on the left side. The first one is A, the second is B. And lastly, beneath the heart, where the heart is like landing, okay, you put another line that passes from one costal border to the other, and this is going to be C. And the formula is very easy, A plus B divided by C. And if it's below 0.55, it's considered normal. If it's above 0.55, it's considered a cardiomegaly, okay? In your OSCE, okay, I think that these particular measurements, you're going to be given actually the cipher, because in the software you cannot measure, okay? So you're going to be given a cipher for A, for B, and for C, okay? And lastly, okay, this is only for, because it's going to be imaging that is going to be shown to look at the different respiratory patterns, okay? But careful, practically all these particular type of questions came with a clinical case. In this case, the clinical case is very important because the information of the clinical case should match with the pattern that we are about to see, okay? So if you know the pathologies, okay, that are caused within these particular patterns, Meanwhile, you're reading, practically you start solving the case, okay? Remember, patterns is how it looks like on a chest x-ray, but the pathology is completely another thing. Example, pneumonia is the name of the pathology, and how it's going to be seen in a chest x-ray as consolidation pattern, okay? That's the difference, okay? So, starting with interstitial, and remember the force of nature, okay? How it looks like a snowstorm, okay? You see, like frosting all the way through, okay? This is going to be the interstitial pattern, okay? When we can check this particular interstitial pattern in a congestion of the lung, in a pulmonary edema, okay, would be the pathology for having interstitial pattern, okay? So this is going to be in a clinical case about this scenario, okay? Then, if you look closely, maybe the clinical case will say that on the edge of the coastal borders, you can see flat lines, okay, at the level of the ribs, okay, that they are known as curly B or curly A lines, okay, that also part of the interstitial pattern, okay, that are these septal lines that we're going to see right here, okay. Then consolidation. Again, remember nature. This is not snowstorm. This is fog, okay. It looks blurry, okay. But look carefully. If you're able to see something inside this particular patch that looks like a branch of a tree, remember that is an air bronchogram. And air bronchograms is only going to be visible in consolidation only. You cannot see air bronchograms in interstitial. You cannot see air bronchograms in nodal or masses or in atelectasis. Okay, so maybe you have doubts about if it's consolidation or not, if it's interstitial or not, but if you're able to see an air bronchogram inside, it's consolidation. Cannot be another thing, okay? So the clinical case should match something that belongs like a pneumonia clinical scenario, okay? Again, you see the consolidation, and you see the branches right here. These look like branches of a tree. That's the air bronchograms, okay? And it's going to be on consolidation. The easiest one, nodal or masses, okay? Why? Because you're going to see a high delimited, okay, picture like this, quite round or oval, but very delimited, okay? So that's why it's going to be easy. Careful, and that's why I like this picture so much. This is not a mass, okay? This is an increment of the aortic node, okay? But this is not a mass, so careful about that. Remember the cardiac silhouette. It's the very first on the top, yes, okay? But it's very round, yes. When you have an increment of the blood flow due to chronic hypertension, the result can be like this, okay? So, and it's more dense. Why? Simply because what is inside the aorta?
Blood?
Blood, a lot of blood, okay? The highest volumes of blood in our entire body is in the aorta, okay? So that's why it looks like more dense than this one, okay? Very good. On this one, cancer, okay? Because it's a tumor, okay? Could be a cyst, okay? But in a cyst, remember that the cyst is liquid content, okay? So how you're going to see that? You're also going to see a flat line, okay, in between because it's liquid, but it's also gas, okay? So you see a circle, okay, then a flat line, and then darker because in the top, because gravity is going to be air, okay? But in this case, practically, because we're seeing nodules or masses, we're going to be focusing on tumors, okay? That is going to be look like this, okay? Very good. And lastly, atelectasis, okay? We have two conditions, two main conditions to have an atelectasis. Like this is a bronchial obstruction. By definition, atelectasis is a lung collapse, okay? This is what it is. But we can have two ways to collapse the lung, from the inside or from the outside, Okay? If it's from the inside, like in this case, it's called lung obstruction. What happens? At this particular level, in the lower lung, on the left side, okay, something obstructs the air. The air is not passing anymore, so that's why the tissue of the lung turns white, because there's no air inside anymore at this particular portion because of the bronchial obstruction. Okay, that is what's happening. Okay, from being an air like density organ, it turns into a solid organ because now air is not passing anymore through that portion of the lung. Okay, so this is atelectasis. Okay, but also we can have another type that is from the outside, stabbing, bullet shot, any sort of accident that creates an entrance, okay, on the thoracic cavity. It's going to enter very drastically the positive air that is from the environment, and it's going to push and collapse the lung. This is the white lung that is completely collapsed, and the rest is going to be filled only by air. Careful about this, okay? Check that this is completely black and nothing else. You don't have any sort of shades of nothing. It's completely dark because it's only air, okay? The lung is right here, okay? And this is another way to show atelectasis, but this is the pathology. This is pneumothorax, okay? The previous one was bronchial obstruction. This is pneumothorax, okay? So check the difference.
The previous one, the white thing in the bottom part of the base of the lung, is that a consolidation or not?
No. This is the lung, but with no air at all. Okay? Remember, the lung is look dark in the chest X-ray because in the entire lung is passing air all the time. But what about if you close, okay, one part of the bronchi and that portion of the lung, not the entire one, the lower portion is not receiving air anymore. The lung is not empty. It's filled with tissue, with blood vessels, with bronchi. They are dense, but without air becomes more dense. Okay, so that's why instead of appearing dark, it's going to appear white because now it's no air on the inside. Okay, and this is the other atelectasis, and that's it. That's my part. Okay, so all the things that. Okay, so careful about the patterns and all the situations about the thing on the X-ray position, alignment, and everything. Okay? Thank you guys. So we continue with the video.
Hello everyone. Did everyone sign this? No? Oh, okay. Is it still passing around? He still needs it?
guys. Okay. This is just a reminder, so you can look at the chest zones, and remember, I'm going to make something punctual. You also need to explore these 3 axillary lines whenever you're performing your posterior thorax examination. Okay, these lines that are over here on the side are also part of the thorax, and you can listen to any respiratory sounds. Very good. Now, the reason why your patient is coming to your consultation on the clinical case on uroscopy, because you're really focused on uroscopies, okay? It's going to be a patient that is coughing, that has phlegms, that has sputum, that has wheezing. Wheezing, we know it's characteristic of asthma, okay? That has dyspnea. Either it can be at rest, or it can be with any other type of physical activity, okay? It can have hemoptysis. What's hemoptysis, guys? Coughing blood, okay? Also chest pain or any other chest abnormality, radiological abnormality, okay? Which is sometimes a reason for referral. Now, okay, we're going to divide your physical examination into 4 main parts. Just remember them. Remember these, and you will be able to remember all your rosters. Okay? We need to perform first inspection, then palpation, percussion, and at last auscultation. Okay? I'll go over some details so you can get it right on your roster. Okay? First, this is the most important part, and this is why we take sometimes points away. See? Always introduce to your patient. See? Always make the patient as comfortable as you possibly can. Of course, you're going to ask your patient to change into a robe with the opening on the back. See? And you need to keep your patient covered as much of the time until you perform your physical examination. Okay? Then, please explain the procedure to the patient. See? I've seen you on your office, and sometimes you just ask, do you consent? Do you consent to what? See? Please explain that you're going to perform an exploration, an auscultation, and that you might touch your patient. See? Please wash your hands or sanitize your hands. Don't forget it. There are 5 key moments where you need to perform hand sanitization, and 2 of those key moments are before you see your patient and after you touch your patient. See? The other ones include the surroundings or any other medical procedures. Okay? Now, since this will be a posterior thorax examination, you need to place your patient sitting down. Okay? And well, we already went through this. Now, the first thing you see on inspection is the kind of thorax. See? Most of us have a normal thorax, but there are some times when you can see an indentation here or an excavation that is a pectus excavatum. I want you guys to know that this is normal. Okay? Patients can have a normal life with pectus excavatum and also with pectus carinatum, which is the opposite. See, the sternum goes out, points outward. Also, we're going to have some pathologic chest types, like this one, a barrel chest. See? A barrel chest is a chest that has basically the same width and the same length. See? It's basically a round chest. And you guys know that a normal chest should have twice the width and 1 times the length. See? Next, we can find spine deviations. See? Remember that whenever we find a deviation like this in our vertebral column, we have scoliosis. And whenever we have a curvature, and hyper or an increased curvature, either in our cervical, lumbar, thoracic, or any other zone, we call this hyperlordosis or hyperkyphosis. Okay? Next, also, once that I've seen the shape of the chest, I'm going to look at the way my patient is breathing. Remember that our normal pattern is from 12 to 20 respirations per minute. See? And we need to look for any respiratory distress. What's that? The use of accessory muscles. Remember, we have our intercostal muscles, and whenever they are exerting too much effort, you can see how they pull, okay, on the ribs. Do you have any questions?
Yes, so we have to take the respirations per minute and before.
No, you don't have to count them. No, you just need to make an approximation. See? You won't be required to report the respirations per minute. It's something that you can just tell.
How are we supposed to vocalize our inspection? What words should we be using when inspecting?
Okay, whenever we find a thorax like this, we need to report it. If we don't find a thorax like this, we just report a normal thorax.
Should we use the word?
See? Yes, you can use the word normal, in this case normal thorax, or you can use basically what I told you. We find a thorax that is twice the length, no, twice the width, I'm sorry, the width is basically from side to side, and 1 times the, which is the normal proportion. See, twice the width because of the 2 lungs, and 1 time the width. If you have 2 times the width and 2 times the length, you will have a barrel chest. See? That's an approximation. After that, guys, I need to check, I was telling you that I need to check my respiratory distress. With the use of accessory muscle, paradoxical breathing, what's that? Usually when I breathe, my lungs fill with air and my chest expands, my abdomen decreases, right?
Correct.
It drops a little bit. Paradoxical respiration is basically the opposite. My chest gets flattened and my abdomen gets bigger, okay? It gets elevated. That is paradoxical breathing. And this, the sternocleidomastoid use. It's also an accessory breathing muscle. See? Also, look at the mouth, at the oral mucosa, because we can find cyanosis there. And we need to look also at the fingers. So we can see the finger clubbing or the coloration. See? Also, we need to look for scars at the chest. Usually, these are scars of thoracotomy, alveolectomy, or even an accident on your patient. See? This is all the things you can see on inspection. Then, we're going to go to palpation. Remember that? We need to assess chest expansion. See? Here, I will ask you guys to place your fingers. I don't mind at which level of the thorax. See, it can be on the upper part or it can be in the middle. Remember just not to go into the lumbar zone because you won't be assessing the lungs anymore. See? Try to leave a space where you don't touch the spinal column, okay? The vertebrae, because that won't expand. You just place your hands on the sides and you ask your patient to breathe in deep. See? And the chest will expand along with your hands. You will have to look at your hands, of course, and you will see that they are symmetrical. If they're not symmetrical, how do you report that? Well, you found a chest expansion, normal in the right side, but decreased in the left side, for example. See? That's just one example. Then palpation. Remember the order: inspection, palpation, percussion, then auscultation. We're on palpation right now. We need to assess the tactile fremitus. See? This is a vibration basically that transmits whenever we We either breathe, or we say, or we talk, we say words, okay? We're going to assess our tactile fremitus on the posterior wall, and remember this has to be in a step-ladder approach, see? The best way I can tell you is that you need to do this without lifting your hand. You need to be able to do this without lifting your hand. And remember, we need to ask our patient to say a word. Which word is he going to say? Well, that is my tactile fremitus. Perro, carro, ferrocarril. You can ask him to say 3. You can ask him to say, what else? 99. See? Whatever word you want. Okay? Every time you ask your patient that, every time you put your hand, he's going to say that word. Okay? And you will have to feel a vibration. If you don't feel that vibration, it means that the vocal fremitus is diminished. And what are the causes why it could be diminished? Why does it get diminished? My vocal fremitus. Because we have, yes, fluid also, but no fluid whenever it's like a little bit of fluid. If I don't have a big, ¿cómo se dice? A hemorrhage or a big pleural or lung effusion, the fremitus will be increased. Remember that water or basically liquid substances increase the transmission of the vibrations. See, so you can have increased fremitus if you have a consolidation. That's the best example. Remember, consolidation is an increase in the quantity of liquid inside the lungs. I don't care what kind of liquid it is. It can be pus, blood, exudates, doesn't matter. See? And if you find it decreased, then you can have atelectasis, which means too much air in the lungs. Okay? You can have a bronchial obstruction that doesn't let the air go in or out. You could have a pleural effusion, pneumothorax, see, which is basically a blocked lung, and pleural thickening. See? Now, if you find it decreased also, it could be due to a chest wall thickening. See? It could also be due to COPD, because remember that in obstructive diseases, the air goes in but can't go out. So we eventually feel our lungs. So fremitus decreases. And that's it. Basically, that's what you can find. Normal fremitus, increased fremitus with consolidation, or decreased fremitus with any other pathology, okay, that keeps air in the lungs. Remember, in a step-ladder approach. I'm going to have you practice right now if we have time, but try to do it without lifting your hand, like, ¿cómo se dice? Making a C shape. See?
Would it be more uncomfortable for the patient if you're rubbing them? Would it be more uncomfortable for the patient if we don't lift our hand?
No, of course. I just want you to imagine that you're not lifting your hand. Of course you can.
Oh.
See? Just imagine that you have like a pen and you have to do it without lifting your hand. See? Just so you can get the pattern that you have to do. Why? Because, of course, this fremitus and everything, palpation, percussion, auscultation, has to be done symmetrically, okay? So there is a way in which I can start looking for it without crossing myself over, see? I think that's all you need to practice. Now, we'll go with percussion, see? I'm going to have you practice that too on yourselves or on anybody else, because I know it's hard. But whenever you perform a posterior thorax percussion, remember to do it on the side of the vertebral spine, see? And also try to find these intercostal spaces, because if you do it over the bone, you're going to get a good sound. And what's the normal sound when you percuss the lungs? Resonance. Okay, you need to find resonance. I practice my bone, I'm going to find fullness. Okay? Remember, the way we auscultate, in which we auscultate, I'm sorry, because it's going to be the same as, in the same order as the vocal parameters. I'm going to draw it here because I want you to have an idea. Okay? Remember, without lifting your hand, your whatever, your finger, we start in here and we go over here. Now down and into the other side. Down and into the other side. And you see the step-ladder approach? Down and into the other side. See? Down and into the other side. And for these ones, of course, you can lift your hand and your stethoscope and you go here, you go over here, and then you go down and into the other side. Okay? That's the correct order. Step, ladder, approach. Okay? Now, we already said that the normal sound was resonance. Okay? You can find resonance in simple chronic bronchitis. That's why you need an X-ray usually to confirm. Okay? When can we find jaundice? When there is a mass or when there is a fluid. See? I can have a true sound if I have blood, if I have pus, okay, or if I have any other pleural fluid in my lungs. That's going to give me a true sound. Also, tumors, any masses, okay? And hyperresonance, we can have emphysema, asthma, and of course, pneumothorax. In the pneumothorax, remember that the negative pressure in the lung is yes, it's equal, that's right, to the atmospheric pressure, so the air goes in and makes our lungs hyper-resonant. Okay? Now, auscultation. Remember, we need our tactile premises. We're on the fourth part of the exam. We already saw inspection. We already saw palpation. We already saw percussion. And there's only left auscultation. First, I'm going to auscultate my vocal parameters. I'm going to do the same, okay? Remember, this is the ladder approach. I'm going to start on the back of the thorax, and you can see this pattern. Look at this. Why I don't auscultate here, guys? Because there's bone, there's scapulas, okay? And the order I have to follow. Remember, first, we need to auscultate the supraclavicular notch, okay? With my belt, with the slimmest part of your stethoscope. And then I'm going to go into the posterior part of the thorax, and I'm going to follow this order. Look. Here I start, and then I go to the other side. Then down to the other side. Down to the other side. Down. I'm sorry, me pasé. And to the other side. Down, and onto the other side. Down, onto the other side. Down, onto the other side. And lastly, I do this. 8, the 8th place, the 9th place, and then I go over here, okay? Remember, I need to inspect twice on the same, basically on the same place or over the same side, and then switch sides, okay? Do you guys have any questions over here? No? A ver.
What happens if I do it 5 times instead of 7 with the reversible?
Oh, it doesn't matter. Remember that the size of the thorax of every patient varies. So if I am auscultating like a 100-kilogram man, of course I'm going to place my stethoscope in some more places. If I'm auscultating a, I don't know, 5-year-old boy, I might just need to auscultate like 5, maybe 6 places at the most. See? That varies, but the important thing is that you cover most of the thorax.
So the first thing is that I cover the
Did you have any other question? What's the same? Okay, guys, please remember to, while you're auscultating, tell your patient to say which word? 33, 99, car, perro, ferrocarril, whichever you like. Okay? And, well, lastly, guys, this is the same, okay? You're going to find an increased resonance if you have consolidation, any lobar collapse or any pneumothorax, for example, or any tumors. And you're going to have it increase if you have a pleural effusion. Previous slide, okay. Let's go in our previous slide.
But the one and one is inside the clavicle.
Yes, on the supraclavicular notch. It's a little triangle above your clavicle, okay? And it's with the belt. After you finish with the belt, you change your stethoscope, your diaphragm, I'm sorry, and you start auscultating, okay? And the last part, once that I have auscultated my vocal parameters, I'm going to repeat that all over again, but I'm going to ask this time my patient to just breathe in deep, okay? And I will have to stay there with my stethoscope for one full cycle. Please listen to this is important. Every time I auscultate, I need to listen to one full cycle of inspiration and expiration. If I go really fast, I won't be able to listen to everything, see? And these are all the sounds you can find, see? I know that you already know how to distinguish between some of them. Remember that crackles usually sound like if you were rubbing like a Cheeto flat together, like a candy wrapper. See? And these are short, discontinuous sounds that are, well, there are two types, or high pitch or low pitch. Okay? And they are usually whenever I have, or they appear whenever I have secretions in my airways. So it could be during atelectasis, pneumonias, fibrosis, or even pulmonary edemas. The point here is that you have liquid in your lungs. Okay? Then, wheezes. Wheezes are going to appear whenever I have a restrictive pathology that restricts the diameter of my airways. And usually, the most popular restrictive pathology is going to be asthma. See? Asthma, bronchitis. If I have secretions, that can also diminish the light of my airway, increasing the resistance and, of course, producing this wheeze. Okay? Bronchitis is also going to be here in the list. Bronchiectasis and a foreign body. This happens to kids usually, not so much to adults. It's like to have things in their mouth and they usually get pulmonary obstruction. You could listen to a wheeze over there. Okay? Stridor. This, you only get it when you have a partial obstruction of your larynx or trachea. So big airways get collapse. Okay? Stridor can be heard on a child's pathology that is called croup, and that's it. Okay? And lastly, the pleural rub. This is also not so common, but remember this is due to the inflammation of the pleura. Okay? You're going to listen to a grating or a creaking sound, and that's it. Okay? Now, this is the last part, and please be really conscious about it. You need to expose when whatever part you're inspecting of your patient. It's never, never, ever okay to place your stethoscope on top of the pelvis, okay? Or to basically try to put your hand inside of the pelvis of the patient. That is also incorrect. See? Over the gown, incorrect. Okay? And over our interior garments, it's wrong. See, the only correct way to do here we have a female patient. Remember to only expose reasonably. See, you're a patient. This is a reasonable exposure.
First, we assess the vocal parameters and the whole part in the front part, in the lateral part, in the posterior part, and then we assess the inspiration and expiration, or how we do it exactly.
You want to know the order in which we're going to perform this?
Yeah, and when we're performing auscultation, should we perform the vocal parameters over the full cycle of vocal parameters, or and then we listen for the inspiration, expiration in each part.
While you assess vocal fremitus, you don't need to ask your patient to breathe. You just need to ask your patient to say the word like 33, 99, carro, perro. He's not going to breathe, okay? Just whenever you take your stethoscope, you're going to give him the instruction to say the selected word. So imagine this is my stethoscope. You place it and I say carro, 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 perro, perro. See? And you start exploring.
So we don't actually listen for the full cycle of inspiration and expiration?
Yes, because this is vocal fremitus, right? After you perform vocal fremitus, you're just going to perform your auscultation. On your auscultation, you're just going to ask your patient to be silent and to breathe in deep and exhale every time you place your stethoscope. Yes.
And then the full auscultation.
Yes. You have to auscultate twice.
That's my question, yeah. I have to auscultate 2 times, right?
Twice. First with the vocal fremitus and then just with the expiratory cycle. So you can listen to the sounds.
So my question is, like, during the auscultation, what do we say? Like, I understand the auscultation, the percussion and everything, but while we're doing it, like, what are we physically saying? Like, oh, I'm gonna auscultate, like, I get that, but are we gonna say anything of our, like, what we find, like, what we're hearing?
Yes, of course, you will have to report your findings. Usually, you will have your mannequin, of course, and you will have to assess, for example, the vocal fremitus. See? You are going to tell me that you're finding a normal vocal fremitus, a diminished vocal fremitus, or an increased vocal fremitus. That's just how you report it. And after that, you have all these tables over here. Todas estas tablas that can guide you towards your diagnosis. If you have, for example, no, this is for percussion. Here, an increased vocal resonance, you can have consolidation. See? If you have a normal vocal fremitus, well, you have a normal one. See? And if you have a decreased vocal fremitus, you could have a pleural effusion. You don't have to learn this, you just have to learn how to correlate. See? For example, if the vocal fremitus is diminished, there is something in the lungs that doesn't allow for the vocal transmission. See? It can be either an excess of air, it can be either a collapse of the lungs. See? And whenever there is an increased vocal fremitus, I have something that is augmenting the transmission of my voice, usually liquid. Vibrations travel through liquid faster or easier than through air. Okay? So I could have an empyema, I could have blood, I could have any other sort of consolidation.
During the auscultation, will we be told, like, oh, this patient has pulmonary edema or something, or we're gonna, like, how do I know to tell you it's decreased vocal resonance if they're gonna be
You will just have to describe what you listen, and we can program our mannequins.
Okay, so they're gonna have, like, their own,
Yes.
okay.
You can have, and I can show you guys, for example, just with the normal sounds. Let me give you an example. What's this? It's a twig. That's a normal breathing sound, right?
Dicen que el pulso no quiere haciendo.
That's breathing. That's what the normally called asthma.
Marica. Suena como una ballena. Se supone que tiene.
Yes, guys.
Se supone
Very
que es
common
un
that
silbato, ¿no?
sample with the normal sounds. I'm still showing them to you, don't worry. Okay.
O sea, bien diferente.
Don't get tangled
Como
with
que
this
no te queda
asthma.
mano, se escucha así.
It's great that you start learning how they listen, okay? You get asthma really frequently, so
Eso
I
es.
don't mind.
Ok.
No, o sea, ella te está enseñando wheezing y eso,
Yes, of course, you can. This is the second person that you have very close to.
Ok, los sonidos nada más.
Okay? You want to hear
Voy a
crackles?
hacer-
Let's listen to crackles.
Está bien. Sí, como decir physiological range. Within physiological range. Check.
Pay attention. These are fine crackles. That's it. That's all the volume I have. But those little, that sound at the end, those little bubbles that you hear, those are the fine crackles. Let me see if you can hear the coarse crackles. These are coarse crackles. Okay. Those bubbling you listen to, those are the crackles. No, it doesn't look like whistling. Do you like to hear whistling again? Let's listen to whistling. A ver, this is asthma. Look. That is whistling. And in asthma, since you're going to have a restriction of the airflow, you're only going to get that expiratory whistling. Okay, guys? Do you have any other question about this? Guys, at the end, I'm going to give you a chance to practice, okay? We're going to continue with our EKG explanation.
Las presentaciones no las van a enviar así. Las presentaciones no las van a enviar.
No son las que tienen que decir sí.
Ah, bueno.
Son las que tienen
Va.
O sea, yo no tengo que romper
Eso no te está un poco distinto, ¿verdad? Porque por lo menos la de X-ray yo sé que está más larga y esa está más brief. Va.
Si esta menos al grano como que lo que va a ver.
Bien. Sí, pues mucho. Te pregunto, ¿y dónde consiguieron el uniforme fix blanco?
Lo compré cuando estaban en la página.
¿Son de Star Wars?
A veces no.
No, ok.
A veces ponen
Sí, nunca los hay.
Hello, how are you?
Nervous? Yeah, laugh just a little bit. Okay, yes, it's normal. Don't nervous, don't worry about it. Remember that in your OSCE, at least at the beginning, Block 2, Block 1, we are mostly interested in seeing you know the techniques, right? Later, we'll have time to scroll, identifying sounds, and that stuff. Just try to focus and stick to that. I'm going to discuss a little bit about the other part of the OSP, that is the exams. I'm only going to discuss EKG because AC base is very recent. We have AC base on Fridays in view, so it's pretty recent. But EKG has been like in 2 weeks, so just a reminder. We're going to do a brief review, just in the scope of the general EKG picture, and I'm going to guide you into specifics. What is going to be the most useful for you in your exercise, all right? And at the end, we'll have a little practice. So I hope you pay attention so you can feel more comfortable in your practice, and then you gain confidence for your exercise. So remember, we have a specific structural ECG analysis. We have to do a lot of things in order to identify if this EKG of my patient is normal or not. But in order to say if it is normal, we have to go through several steps. We have those 8 steps. Of course, there are more that we can add up. We can omit some of them. But those are like the most common that we tend to use. First, we have to see if the rhythm is regular or if it's not regular. We have to calculate the axis, heart rate, and then we have to go way by way, segment by segment, to see if they have the normal duration and amplitude. Okay? If we go through all of those measurements and everything results to be normal, now we can consider it sinus rhythm. The main goal for today is for you to identify sinus rhythms and non-sinus rhythms. Okay? As we said earlier, then we'll have time about 7 to learn arrhythmias and infarction, so you'll have enough time to worry about that later. What is regularity? We're going to go through the specific steps. So, very important, guys, for you to remember the specific concept. Because it's not the same sinus rhythm as regular rhythm. It's not the same. Because we have arrhythmias that are regular. Yeah, it sounds confusing. But we can have arrhythmias that they are regular. Okay? So what is regularity then? It's not the same as sinus rhythm. Regularity is the distance between one heartbeat and the next one. Okay? So, if the distance between every heartbeat is the same, we will have a regular rhythm. Regular. You can even imagine. Okay, like try to imagine it. I know it's hard to use imagination on EKG, but once you do it, it's very helpful. If you see the EKG, try to hear it. Boom, 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 boom. You know that the lines are equal to time. So if the between QRS and the QRS they have the same time, so they have a normal rhythm. Boom, 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 boom. Regularity. Right? And then we also have irregular rhythms. So just for wrap this up, it's not the same regular rhythm as sinus rhythm. Do not confuse it. Regularity only means the distance between QRS and QRS. And if you see over here, you can see that the distance between this QRS and this QRS, it is very different than the distance from the next. Okay? So if you also want to imagine, you see that this has no rhythm, like boom, 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 boom. No rhythm, irregularity. Now, remember, the things that we hear on the auscultations is balls. Closure and opening of balls. Here in the EKG, we're actually seeing the conduction system, the electrical conduction system. So it's the valves are part of the mechanical system of the heart, the pumping of the heart, and the EKG is the electrical part. All right? But you will hear that irregularity. So regular and irregular. Very important first step, because the next step depends on if it is regular or irregular. That is, what is the next step? To be checking the axis or checking the heart rate. So very important to identify if it is regular or not. Because if it is regular, we can use one specific formula, but if it is irregular, we have to use a different formula. So do not get confused by that. We're going to discuss a little bit about the axis. Okay, I'm going to give you enough context For in case at this point you haven't really understand the axis, I'm going to give you a little bit of context, so maybe it's easier to learn it that way. So remember that in the heart we have energy. The energy goes from one point to the other. We have this that is called the activation dipole. That is basically, we have electrons on the body. And if the energy is getting closer to the electrode, for example, this is the electrode over here, the electron is going to see the positive part of the energy. So I will have a positive deflection. If the energy is going away from the camera or from the electrode, you will have negative deflection. Okay, so that is something to keep in mind for the next thing. Now, remember that the AKG, it's basically a representation of the conduction system that we mentioned before. So every part of that conduction system has specific functions. Sinus node has a function of, which is a function of the sinus node?
The electrical power patterns. Sí, yo he firmado. Bueno, no sé si es la
It's
misma.
the pacemaker, it's the one that actually tells you how fast you have to go. For example, if you all start here and start doing sit-ups, or right, or start rolling around, the sinus node is going to receive some signals in order to increase the heart rate, to increase the cardiac output, and give you enough oxygen for your activities. If you're going to sleep, I hope none of you are sleeping right now. Maybe a couple. So your heart rate will be decreasing, alright? Will decrease because you require less oxygen. Okay? So that's the main function. Then we have the internal pathways. The function of the internal pathways is to connect the impulse, the energy impulse from here to the next structure, is the AV node. So, one question for you guys. Where do I see the sinus node in the AKG? In which wave or segment, or in which how the sinus node is represented in the AKG? In the B wave? You sure? Okay, the B wave is the depolarization of the atrium. Okay, guys? But the sinus node is the energy of it's depolarizing the atrium. It's just the spark. The sinus node is just the spark. The structure that actually does the depolarization are the internal pathways. So imagine the sinus node just as an interrupter. Energy, spark. The actual thing that carries out the depolarization is the energy traveling through the atriums. First through the right atrium and then through the left atrium. So that is how the energy travels around the atrium, and that's what the result of the B wave, the energy traveling through those structures. Then what happens? The energy arrives to the AV node, which is the main function of the AV node, guys. AV node, main function. What? Okay, yeah, but what is the function? What does it do? Okay, it receives it, so it's basically the middleman between atriums and ventricles. But it does something very special, that is, pulse. Okay, so remember, the energy travels very fast. Energy travels meters per second. So what will happen if my heart will depolarize all at the same time? Atriums and ventricles will contract at the same time. And does that happen? Oh, no, right? Because it's not efficient. It's not that. But the thing is, atriums have to contract first, so ventricles can be filled with blood. So the main function of the AV node is to receive the energy. It's going to make a little pulse. It's going to hold the energy so the atriums can contract and the ventricles can be filled. Once I make that little pulse, as you can see, there is no energy going anywhere around. It's just staying in the AV node, letting the atrium contract. Once the atrium starts finish the contraction, now the ventricles are full with blood. Now I can release the energy and carry out the ventricular contraction. And that is what makes my QRS. Why is this important, guys? What is your definition of sinus rhythm? That is important. What is your definition of sinus rhythm? Sinus rhythm is when all of this happens in my heart. If something different happens, then it's non-sinus. That means that the sparkle may be out of the sinus node, maybe in other place. Maybe the AV node is not doing the pulse, or maybe it's doing a very prolonged pulse. Alright? Maybe my QRS is not being activated as normal, but being activated in a different way. So that will result in different or alterations in the EKG. The most common is PR interval can be prolonged and the QRS complex can be wide. So pay attention. If you identify a PR interval prolongation, sinus or non-sinus, what is going on in the heart? AV block, because the AV node is the one in charge of the pulse, so if the pulse is prolonged, something is going on. What happens if I have a prolonged QRS complex? More than 0.12 seconds. Something is going on at the level of it could be the branches or the Purkinje system. It could be left of the branch node, right of the ground node, alright? As I said, you're not cognitive pathologist, but something is going on in the vein. So for that is, remember the normal measurements and how to measure. Okay guys? Questions at this point? No? Okay. So now remember that the EKG is a three-dimensional picture. We have frontal leads that are the ones that we place on the hands. ABR, right hand, ABL, left hand, ABF in the foot. Those are the frontal leads. So they divide the heart in this position. And then we have the horizontals that are from B1 to B6. Those are the horizontal leads. All of them are very important, but when we assess rhythm, we focus the most on frontal leads. I'm going to tell you why. So that's the body, right? You have ABR, ABL, ABF, ground, and ABF. That's the heart. Okay? So imagine, and all of those leads are cameras. They are receiving signals from energy. If the energy goes away from the camera, I will have a negative reflection. And if the energy comes towards me, I will have a positive reflection. So now, those are, as I mentioned, maybe all of your ABF. But what about D1, D2, and D3? Where are those?
Where are those?
Do you remember? So we have unipolar leads that are basically the cameras, but then we have bipolar, right? D1, D2, and D3, I really do not place them in the chest of my patient. Those are, we get those leads by some equations. We're not going to mention them. But for example, we have D1. D1 is just at the center from ABR and ABF. So basically, it's not only seeing one specific thing. It's taking both leads and seeing which one is more positive and more negative in order to see where the energy is going. The same happens with D3. But something very important, guys. Why do we always check D2 in the EKG? Because you must have heard this. Analyze the EKG in D2. Always ask for a long D2 lead. Why? Okay, this has something to do with that, but why? If you use the same logic, every lead is seeing different parts of the heart. D1 is mainly seeing the superior part, alright? D3 is mainly seeing like a posterior inferior part. But if you pay attention to D2, D2 is going straight above the electrical conduction system. So basically imagine if the EKG is a house, if the heart is a house, and every lead is a camera, and they are at different windows of the house. We have a camera on the living room, we have a camera on the bathroom, weird, but maybe. So imagine D2 as the camera of the heart that is directly looking at the electrical conduction system. That is why all the measurements from the heart, all the segments, pure interval, pure responses, are more accurate on D2. So focus on D2, guys. Now let's discuss the axis, because we mentioned unipolar leads and bipolar leads. But what is the axis? So all of this energy has a specific direction. It has a source and a specific side when it is born and a direction. If we imagine the heart as like this, we have the sinus node, we have the AV node, and the ventricles. We have a lot of different vectors that we are going to mention, but if you would like to calculate the overall energy, you will see that the energy goes from here to here to here. Alright? So we will have one main vector that goes from right to left, from up to bottom. So the energy is going this way. Alright? So this should be the normal axis of every patient. So it is useful to calculate the axis? There are a lot of applications, mostly to help us to identify pathologies. Because EKG tends to be like not very specific. We can have some details around, then we have to look for other details. So the deviation of the axis helps us a lot. Alright, it's more information. Actually, we can calculate the axis different ways. We can be as exact as we want. There is actually a formula that can tell you if you have 68.03 deviation. But for the normal EKG or for the limits of this review, we are only going to focus in 0 to 90. Okay? That is the normal axis. If you look at different biographies, some of them use -30 and 110. That can change a little bit. But let's stick to 0 to 90. Okay? Now, how to calculate, guys? You just have to look at two leads. Which? D1 and ABF. We can also use D2, but that is a different technique. Okay? You can also use it, can be useful during the test. But the one that I will show you is the one that is a little bit more straight to the point, more easy to do. And it's very accurate. Okay? So we're only going to use ABF and D1. I'm going to explain to you a little bit of why. Why do we choose D1 and why do we choose ABF? Okay? So if you look at a triangle, we have D1 and we have ABF. So D1 is not actually a lead. This is a bipolar lead, alright? It's not actually a camera. So what it's telling you is if this is more positive than this one. If ABR is more positive, that means that the energy is going that way, right? Okay, if ABL is more positive, it's going to tell you that the energy is going that way. So that is how D1 helps me to identify if the energy is going to the left or to the left or to the right. Okay, guys? So, if D1 is positive, this is telling me that the energy is going from right to left. Perfect, from right to left. If D1 is negative, it's telling me the other way around, that ABR is more prominent. So the energy is going from ABL to ABR, so from left to right. And if D1 is isobiphasic, this means that the energy is not going to one side or the other, it's staying at the center. But focus at these two things, right? D1 tells me if it goes from this point to this one or the other way around. And ABF is a little bit more easy because that is an unipolar lead. So it just tells me if it is go close or away. So if ABF is positive, that means that the energy is going down. And if ABF is negative, that means that the energy is going away. So with that said, We only choose those two because they're going to tell me if they are going from right to left and up to down, two axes. Now, first example, guys. Okay? Pay attention. D1 is positive, so the energy is going from right to left. ABF is positive, so the energy is going down. And if the energy is going from right to left, from up to down, the axis will be placed at from 0 to 90. And what is happening in my heart is that the axis is normal. Do you see how the energy is born at the sinus node and it travels to the different structures? Alright? Perfect. Now we have negative D1. What does negative D1 mean? From left to right. But ABF is positive, so it's going down. So if you translate that to the diagram, then we have that the energy is going. It has right deviation because it's going from left to right. So it has right deviation, and something is going on the heart that produces this deviation. Okay? No, the same. This is another example. What happens if ABF is negative? It's going up. If D1 is positive, it's going right. It's going left. So, our axis is left axis deviation. Okay, something is going on in the heart that produces that deviation. And we have this last example. What if both are negative? It's going from down to from bottom to top and from left to right. So it's going basically the other way around. So that is extreme axis deviation. So if you look at ABF and D1, pay attention which one is positive. It's going left or right, or if it's going up or down. That's going to help you to see like more as a more logic way to calculate the axis. Questions? No? Sure? Perfect. We're almost into the practice, okay guys? Now, heart rate. Straight to the point. Remember, if it is regular, use the precise formula, guys. Use the precise formula. Count the small boxes and do the division. Count how many boxes there are between our QRS and the next one, and divide 1500 by that number. In this case, we have 19 small boxes, so we do the formula. So our precise heart rate is 79. You will have time to calculate, don't worry. But what happens if my rhythm, if it is irregular? Alright? If it is irregular, I cannot really use the same formula because it will be different depending on which QRS I chose, right? So what I'm going to do is I'm going to draw a line at the beginning of the strip. I'm going to count 30 big squares and draw another line. That equals to 6 seconds. I'm going to count how many QRSs they are, in this case 13, and I'm going to multiply it by 10. This is actually easier, right? Because you have to do a multiplication by 10. But it takes a little bit more longer because you have to count the boxes. Alright? So this is the one that we use with irregular rhythms. I know they have also teach you one that is with 12 seconds, but you have to multiply by 6. Do not get confused, guys. It's all the same formula. If you take more squares, then you will multiply by less, right? So 30 big boxes and multiply by 10. Okay? Perfect. Now, P wave. Remember, the P wave is supposed to be positive in specific leads and negative in specific leads. Let's focus on the negative. ABR always has to be negative. If we have a positive P wave in ABR, something is going on. It's not normal. D3 and sometimes ABL can have a negative P wave. Alright? Can still be considered normal. And what about V1? As you can see in V1, ABR, remember, always negative because all the energy is going away from the camera, so always negative. But here in B1, we have this. That looks not very normal, right? It is positive and then it's negative. Is that normal? Do you think that's normal? Okay, it is normal. Alright? So we have to identify two things. Some things that may look abnormal, but they're actually normal, and some things that may look normal, but they're actually abnormal. So in this case, B1 can have that morphology, because the first part of the P wave is only the right atrium, and the right atrium is actually going closer to the camera. But the second part of the P wave is the left atrium, and in that case, the energy is going away from the camera. So we will have a first right atrium, that is the energy going towards the camera, and then the right atrium, that is the energy going away from the camera. So that can be a normal morphology. Alright guys? Now, PR interval, remember the beginning of the P wave to the beginning of the QRS. Normal duration is, which is the normal duration? From 0.12 to 0.20. Okay? No less than 3 small boxes, no more than 5 or 1 big box. Alright guys? Perfect. T wave can also be, is supposed to be positive in most of the leads, always negative in ABR, and can actually be considered normal in B1 or in B2 even in some patients. Female patients, younger patients, athletes. They can also have negative T wave until B2. Negative T waves on B3 are avoided. Okay? Perfect. ST segment, remember we have to draw the baseline. We will have to assess if we have elevation or not. If we take this as an example, the ST segment is elevated or not? It is. Is that an inversion? It depends. Alright? We're not really going to focus on that much on infarction right now. We will have plenty of time to assess that. But in order to be considered infarction, we'll need to have elevation in 3 leads, not only 1. If only 1 is elevated, it's not considered infarction. It has to be at least 3 leads. Alright guys? Questions? Questions? Sure? Okay, we're going to do a practice. Alright, I need you to grab a piece of paper, or maybe you can write down in your computer, your phone, but you will see an EKG for just 1 minute. Okay guys? And for that minute, you will have to look at the regularity, axis, heart rate, and rhythm. Okay guys? Okay, you think you can do it? Just 1 minute per EKG. Alright? At the end, I will give you the answers of all of the EKGs to see how much you get right, how much you get wrong, and how you can improve your clinics, okay? I'm going to give you just 1 minute because most of the time in questions, in every exam, you have only 1 minute per question, okay? So you ready to start? Sure? Perfect. So, we start right now. 1 minute. Yes, 1 minute per EKG, remember? 50, that's called the AKG.
No joda. Sí, yo no uso esa palabra. Nosotros usamos eso que raro. Nomás la vaina. Sentarse a dedicarle un día completo a esa pendeja. Y es que yo no. Ah, este cabrón. Ah, me enviaron, no he chequeado. De juicio. Sí, es verdad. No me notificación, pero no lo he mirado.
The exercise was for you to try to look fast and answer fast. Remember, formulas are very straight to the point. You can either multiply by 10 or just use the formula from 1500. Axis, D1, ADF, deviation. Alright, so this is for you to practice. Your answer sheet is supposed to look like this. Alright, guys? So those are the answers from MBAG.
Tenemos una sabe.
Now, before we end up, I would like to focus on those specific answers because those can be a little bit difficult. Alright? So first, let's go to EKG number 4. Does this look like sinus rhythm to you? Does this look like sinus rhythm? Because the answer is sinus rhythm, right?
We always consider also the actual.
The archward, it is regular. The PR interval is less than 1 big box, right? Perfect. ABR is negative. P is negative. The rest of the leads is positive. We have something that looks like the infradecibel of the ST segment. But as I mentioned, we don't have to focus that right now on that, right? That's not really interferes with the rhythm. So yes, it looks like not very normal, but if you look at it, it is normal, all right? Then the next one. In here, sinus or non-sinus? Which is the duration of the QRS? It looks wide or narrow? Just from seeing the AKG, you see that the QRS looks wide, all right? So, non-signed, right? The axis, we have negative ADF and positive D1. Where is the axis? Going up and to the left, so it's left axis deviation. All right, perfect. In here, also the question was, you see this? Okay, it looks very bad. It is. But you have to focus on that at this point. That is the main reason. Focus on the heart rate, focus on the axis,
Se salió y todo.
focus and see the B wave is positive and negative. Right? And the last one. Guys, how do I calculate the axis? Using this extra bit or the normal bit? For example, in this case, we have D1, positive in both, but in here, this one is positive and this one is negative. Do not get confused. Use the normal bits. Okay? This is the normal bits, this is the normal bits. But that they don't have P waves, they are something called extra contractions. Do not worry about it. Just know that you're going to use the normal in here and the normal in here. Also, you count all of them or only the normal ones? You have to count all of them. Okay, guys? So, I know EKGs, they can look very different, they can look pathological, they can, but focus on the things that I showed you. Okay, guys? Questions?
Yes. On the bottom, back to the bottom one, we accidentally
Seven, perfect.
¿Cómo lo va a contar? Probablemente como el examen, porque es lo mismo, eso va a cambiar. ¿Te acuerdas con el examen? Contar los cuadrados, contar los segments, qué significa, qué te van a enfocar.
In this case, you have 6, it's 5, so it's very hard.
Vale, sí. Están grabando profesionalmente, no sé si con esa cámara, pero yo creo que
The things are the same. Okay? So, guys, you have no more questions? I will share those images with you guys, and there is my email if you need anything else. Okay, guys?
I think the only thing that we're missing is the cardio block, but I can do it really
So I know the review is over. That was a lot of stuff, but we still have the cardio examination. You're more than welcome to stay, and Angie's gonna do it in like 10-15 minutes tops. So we'll review everything, check this, clarify any questions we have, and then after that we'll adjourn the session. Does that sound good for everyone? Yeah. Also, do you guys have the sign sheets still?
hay distintos métodos también.
Did everyone sign already? No? Oh. Alright,
I have a quick announcement. On your thorax examination checklist, you guys have something in the part of percussion.
Yes.
So remember, thorax is only going to be focused on the posterior part. So when it says percuss anterolateral, we're just going to percuss, as Dr. mentioned, this area. Okay? And the only part anteriorly that you guys will need to listen to is going to be the apex, which is heard here. Remember, important when you're changing the stethoscope from the bell to the drum, say it out loud. Make sure the doctors know that you guys know what you're doing, okay? So, OSCE, you guys are in block 2, you're gonna see this throughout. It's really about letting the doctor know that you know what you're doing. Not only by doing, but by saying, okay? So, remember. You can say, when you're doing percussion, so right now it's only for the normal. but professors here don't like the word normal. So remember, physiological, okay?
And the normal sound in the lung when you percuss it, resonance. You can use that you found a resonant sound, which is normal. Or physiological, yes, it's okay.
Yeah. For the OSCE, for this one, just listen to the regular lung sounds. Because when you get to the second part, you will have to identify pathology. But that's only for the second part. For this one, remember, so you have vesicular sounds. Lung sounds, normal, vesicular sounds, okay? For cardio, which is gonna be on the anterior part, remember what Doctora was saying. It's important that you take into consideration your patient. So if you don't have to expose them completely, don't do it. If you're doing one side, for example, for cardio, you're going to focus mostly on this area. So if you can just have this area not completely uncovered, mostly in women, then that's to make your patient feel more comfortable, okay? Let's go ahead with the checklist for the cardio. Anyone have another question? Sorry, before I begin cardio. So obviously remember, watch your hands, introduce, ask for consent. So now we have a rubric. Every time you forget something, there's points taken out, okay? So those are the basics, and it's for you to have soft manners. You're gonna need them when you're on your clerkships. So not only for the exam, just use it to get used to the way you're going to treat your patient. You're going to expose the anterior thorax of your patient, asking for consent, remember. You're going to inspect. For inspection, what are you guys looking for? Can someone tell me? Any discoloration, any scars, any mass, anything that's going to be particular for a pathology, okay? So just try to describe at least one or two. Make the doctor know what you're looking for, okay? Even though we know it's gonna be a mannequin, but assess the mannequin completely and state all that you can. You're going to palpate the apex feet, okay? So remember, where is the area that you're going to find the apex at?
Upper.
So regular patient, maybe you won't be able to feel the apex. Some techniques for you when you're on your daily to find it, you can ask them to bend a little bit forward. Skinny patients are usually the ones that you're going to feel, but if not, you can ask the patient. And remember, if you have a woman, you need to ask them to what? Lift the breast, please. Use the correct words. There's sometimes students that forget and use the word boob or something, please, okay? Be respectful. So can you please lift or retract your breast and do I have the consent if you're comfortable, blah, 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 just ask and do it. The same thing for the auscultation. You're not gonna place this stethoscope open. So you have to ask the patient to lift and then you're going to try and look for the area. In men, it's way more different and easier. So, yeah. You try and feel the apex beat, and what will you say? The beat is present. Okay? The apex beat. For auscultation, you're going to do two auscultation or two cycles. One's gonna be done with the drum, and one's gonna be done with the bell.
That's right. Do you want to represent me? I have to over there.
Okay, so important for this exam. The location. You guys need to mention the location every time, and they want to see you guys locating the area. So don't just go straight to the mannequin and place the stethoscope. Look for the intercostal spaces. I'll try and show you soon. So count them out loud, place the stethoscope, and say where you are listening, okay? So for each point, you're gonna do the same thing. And you're going to auscultate first with the drum, and you would say, hard sounds are present. Okay? When you go to the second part, which is gonna be done with the bell, you're trying to listen for more, let's say,
It's a less to sound.
Aquí.
Es como un pequeño galope. Exacto. It's like when a horse is running.
and for the split of the okay, so here, split of the S2. Okay, so that's gonna be which area are you going to listen for in the S2 split? In which point? Anyone knows? What are you gonna say when you're in the area for you to be able to listen to the split? Take an inspiration. It is hard. I don't know if you guys have been able to hear the split. It is there. You just have to concentrate on the hard sound. So when you hear the inspiration, you can focus on the split. If you start listening to the inspiration, you won't be able to catch the split. But at some point you will get it. Remember, as I told you, important when you're changing from one side of the stethoscope to the other, make sure you're same. After the split, you're going to cover the thorax because you won't be doing anything else. Okay, so for now, you just want to cover the thorax and make the patient feel comfortable. You're going to proceed to the capillary refill. So you guys know you just press and let go and assess the time it takes for you to see the refill. So how would you report? Capillary refill in less than 2 seconds. So something prolonged, more than 2 seconds, it's going to be possibly pathological, okay? So you would do it and compare bilateral, okay? Always compare. Because if we do have refill here, but we don't have refill here, then where's the problem? This side, okay? So always, most of the time. Other fingers. Will they permit just one finger bilateral?
Yes, one finger on each side is straight.
Yeah.
1 or 2 fingers.
For exam purposes, obviously. When you do in real life, try and be thorough, okay? And then we're going to proceed with the poses, okay? For each pose, listen. Don't just put your feel. So just put your hand there and say, okay, pose is present. Some mannequins do have the poses, okay? So make sure you try and feel them if they're gonna be present. You're gonna start with the cowtail pose. Remember, one at a time. Don't be putting both at the same time. Then you're going to proceed with the upper limbs. So for the upper limbs, okay, and important, for the report, remember it's gonna be based on if it's present, if it's bilateral, and if it has a good intensity, okay? So for each pose, you're going to identify bilateral or symmetric, intensity, and that the pose is present, okay? For the upper limbs, we have the radial, the brachial, and the axial. The order, do they have to start proximal to distal?
It doesn't matter. It's only what matters is that you do it.
Okay, so it's up to you. For me, it's better distal to proximal so I don't forget. So you would start axillar, brachial, radial. Okay?
And also, I'm sorry, bilateral, comparative. That's really important.
Yeah, it is important to start proximal. Start proximal, for example, the axillar, and then compare to the other side. Then go to the next one, then compare to the other side. But it is important to go from proximal to distal. That is important, okay guys?
Proximal to distal. Okay? And so you guys don't forget the radial. Un radio tiene antena, so radial. It's always on this side, okay? Don't forget. Then you will proceed with the lower limbs. So again, for every report, intensity, present, and if it's symmetrical or bilateral. And again, proximal to distal, okay? So you're gonna have the femoral, oblivion, posterior tibial, and dorsalicales.
How should we vocalize the intensity? How should we say it? It's present and symmetrical and intense.
And with good intensity, so you're able to feel.
With good intensity.
Yeah. Diminished intensity would be if you struggle to get the pulse, to feel the pulse. So that would be diminished. Any questions related to the pulses? Please remember to compare every time, okay?
Does it have lips? How would you
You're probably gonna have the
Sí, man.
recontado.
Yeah.
Yeah. So you're gonna use the mannequins that are laying down, and they do have all the limbs. There is one that doesn't have an arm, but you would only just verbalize. So in case you encounter that, just verbalize. I would do comparative test of the pulses. And so for the Allen test, so basically what you're going to do is you're going to occlude both arteries, and you're going to release one at a time. So you want to assess first one and then the other one. There's no order as long as you do both, okay? So occlude both. You can ask the patient to open and close the hands so you can see that there will be the riffle. So the hand's gonna be white. And then when you, cuando sacas el dedo, it's going to refill. So basically this is another refill test. And you would also report that there's refill in less than 2 seconds, or refill is present, and doctor, is it also 2 seconds, in less than 2 seconds?
Well, actually here is not the thing about time.
Okay.
But remember,
This is present.
you're assessing collateral circulation. So the ulnar and the radial artery both are supposed to cover the whole hand. So if you can see the Allen test on the picture that has only half the hand that is returned the circulation, that means in that specific case that the ulnar artery does not provide oxygen to the whole hand. Alright? So that is pathological. It does not really, it's not really about time. How much time does it get? It is how much of the hand it covers. So for example, in that case, I will not use the ulnar artery to take an ABG, for example. Because if I produce thrombosis of that artery, then I will lose my whole hand. Alright?
Yes.
And then the Bowman sign, it is for the presence of deep vein thrombosis. You're gonna ask the patient to lift the knees. You're gonna have them laying down. You're gonna dorsiflex the foot, and while dorsiflexing, you're going to squeeze the calf. Okay? So a positive sign would be if the patient screams or complains about pain. Remember, if you do it on yourself, you're going to feel some type of discomfort, but the pain has to be real, okay? So it's going to hurt them, and you will see the leg probably can be swollen or can have a type of discoloration or something. So assess that. The mannequins, you guys know that they make sounds. So remember that, and don't get scared. Because if you do the comments and the mannequin screams, then what are you going to say? Hoffman sign is positive, okay? If you wait, you do the test and there's no reply, the doctor could say something, ouch, or something like that. So be aware of whatever you hear at the moment of doing the exam. And remember, dorsiflex legs with the knees bent, okay? And this table, you guys need to review the table. They could do open questions at the end, and they're gonna want you to understand what are the differences between having arterial or venous insufficiency. Okay? So it's really important. They are different. Okay? So recall which is which, and important. The inspection and then at palpation, you wanna assess that the pulses are present, that the temperature, if it's either hot or not, and if there is edema. So edema, you would compress or press the skin, and then you would assess. Sí. Press.
Should we do it in the examination?
If they ask you to do examination for this, last time it was only open questions. So identifying what are the differences, okay? But they do ask you what are you looking for in an examination. So presence of edema, pulses are present or not present, and how's the temperature of the area. Okay? Here is insufficiency. I think you guys have this right on your presentation. And so, any questions related to the process of doing auscultation? No. Remember, important, bell, drum. Make sure you guys, when you get into the room, know in what, en qué lado está, okay? So start, you can acknowledge to the doctor that it is here and I'm changing it to the bell or the other way around, okay? So remember. Anything else? Remember for thorax, the anterolateral part, don't focus on that, just remember doing percussion in this area, okay? This area and respecting the areas that you won't listen for anything.
It's only percussion, you don't have to do like auscultation.
And the auscultation too. So follow the step ladder. When you're on an exam, you're gonna get nervous. It's true. Just remember that everything in medicine you're gonna want to compare. So if you start here, then you're going this side. Then you can go down, but you have to compare this side. So look at it that way. The same thing for when you go in here. I would struggle. But then I was like, okay, let me remember that if I do this part, I have to compare here, and then I can change here, but I need to go back to the other side to compare, okay? So more than just remembering is the ladders, whatever step ladder, just remember you want to compare both sides, okay? So you go, doesn't matter how you start, as long as you compare, you're gonna have the right technique, okay? For percussion, the same thing, remember resonant, and the vocal fernitus, if it is increased or decreased. And I think that's it. Any other questions? Yes?
When we're testing for pulses, do we have to test for both arms and both legs?
Yes. Yes, compare proximal to distal and you compare. So you do axillar and then you go to the other side.
Okay, so is it, you said proximal distal before, so it'd be proximal to distal one arm and proximal the next arm?
Yes. But comparing each time. So if you do axillary, you have to compare axillary.
Okay, so it's proximal, and then work on.
Exactly, yeah.
Okay.
But in each limb, you will go from proximal to distal, proximal to distal. Okay. So just try and feel. There is pulses that you will feel. There is others that you won't. Obviously, in the part that the downbeat is, the mannequin is like this up, there will be a pulse. Where there's supposed to be a pulse, the doctor will tell you. And then on the hard parts, then you won't be able to feel, but you need to act out as if you're feeling the pulse, okay? So don't just put it and say, okay, pulse is close, no. Like, you know, when you get a real patient, you're gonna be there trying to figure out if it is present, has a good rhythm, intensity, okay? So for real life scenario, remember, it's not just placing, feeling, that's it. No, assess everything, rhythm, symmetrical, intensity. What else? couple of times. What else? X-ray, just try to go through the presentation. It's gonna be helpful. So go through the presentations. You guys will have images in the exam. A couple of EKGs also in the exam sub. But you guys got this, okay? Any questions that you have, you can send a message through Instagram. And if you see us around, which I think you won't, because I know you guys end next week, but please don't feel you don't have anyone, okay? So reach out. We're here to help you, professors and CSD mentors. But yeah.
Thank you.